1, 2,
And maybe female.
Oh shit, I almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
Let's start with
300 please.
I'll keep you on again.
Pulse check. No pulse.
no more pulse.
Yeah.
Here, what are the echo people get?
And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh.
Okay.
Oh.
You know, usually when we talk about a medical diagnosis, there's this comforting expectation of absolute precision.
Oh, totally. Like it's engineering or something.
Right. It feels very linear. Like if a patient comes into the emergency department and they've, broken their arm, the process is just so straightforward. You get an x-ray, the image pops up on the screen, and you see that jagged white line right through the radius.
Yeah, and the doctor just points at it and says, there it is. There is the problem.
Exactly. It's totally binary. I mean, the bone is broken or the bone is not broken. And the treatment path just dictates itself based on that highly visible, very static piece of evidence.
It's clean.
Yeah.
And I mean, as humans, we love that. We love things to be visible and, perfectly categorized.
We want everything to fit into neat little diagnostic boxes. But then you step into the world of obstetrics.
Oh, boy. Yeah.
You step into maternal-newborn nursing, and suddenly that comforting x-ray machine is just completely useless. The boxes disappear. You are looking at a diagnostic landscape that is, quite honestly, incredibly murky.
Because you aren't just assessing one patient anymore, right?
Yeah.
You are dynamically, simultaneously monitoring 2 and sometimes 3 or more patients at the exact same time.
Which is wild to think about.
It is. And their physiology isn't static. It is constantly shifting, constantly adapting, and unfortunately, sometimes constantly failing.
It's the absolute definition of diagnostic muddy waters. And for a nursing student or, even a new grad nurse stepping onto the labor and delivery floor for the very first time, that ambiguity can feel just incredibly overwhelming.
Oh, absolutely. Because you're expected to look at a patient who is experiencing these profound systemic physiological changes and instantly discern whether what you're seeing is a beautiful, totally expected adaptation to pregnancy.
Or the first subtle whisper of a catastrophic emergency.
Exactly. And that is exactly why we are here today.
Yes, welcome to the Depth Dive. Today, we are talking directly to you. Yes, you. The ultimate nursing student, the future safe practitioner.
The one who's probably currently staring down a massive mountain of OB nursing textbooks.
Oh, and the hundreds of lecture slides, just feeling completely buried by the sheer volume of information. We've all been there.
We really have. But our mission today is highly specific, and it's entirely tailored to your success. We are stepping into the roles of your elite OB nursing educators, your exam coaches, and your clinical mentors.
We took a massive stack of OB nursing source material. I mean, literally everything from antepartum care, baseline maternal adaptation, high-risk bleeding emergencies.
All the way through systemic complications like hypertension and diabetes, preterm labor, and even those sneaky maternal infections.
Right. And we are aggressively applying the Pareto principle to all of it.
The 80-20 rule, meaning we're going to mine the 20% of high-yield concepts that will get you 80% of your exam value.
But honestly, more importantly than any exam, this is the core knowledge that is going to keep your future patients safe. Like you're drowning in textbook pages that treat every single fact like it carries equal weight. But we know that's just not true in clinical practice.
Not at all.
Yeah.
We're going to sift through the noise right now. No fluff. Just what actually matters for your prioritization, your clinical judgment, and your ability to spot danger before it strikes.
So what is truly fascinating here, and what you absolutely must understand to pass your exams and be a safe nurse, is that OB nursing isn't just about memorizing isolated facts.
Right. If you try to just memorize a disjointed list of symptoms, the NCLEX and your nursing instructors will completely crush you.
Because they aren't testing your memory, are they?
No, they're testing your pattern recognition. That's the key. We're going to focus heavily on maternal and fetal safety. We'll separate the expected normal findings from the urgent red flags.
And as we navigate through this, we'll be explicitly pointing out the classic traps that examiners absolutely love to set for students.
Well, they love their trap.
They really do. Okay, so before we can even begin to identify a life-threatening emergency, we have to establish what a normal pregnancy actually looks like.
Because the maternal body, undergoes an absolute physiological earthquake. If you don't understand the baseline, everything looks like an emergency.
Let's start with a classic expected change that always seems to trip people up. We know a pregnant patient's blood volume goes up massively, right,
Yeah.
to support the growing fetus.
Huge increase, yeah.
But if they have so much more blood, why on earth did they consistently become anemic? To me, it sounds like diluting a rich soup by just pouring in way too much broth.
That is actually the perfect analogy for what's happening on a cellular level. Let's really unpack the baseline hemodynamics of pregnancy, because this is foundational high-yield material.
Okay, lay it on me.
So, during a normal pregnancy, the maternal total blood volume increases by anywhere from 30 to 50%.
Mm-hmm.
The body is essentially hypervolemic, but blood is made of different components, right?
Right. You have the plasma, which is the liquid portion, so the broth of our soup.
Exactly. And then you have the erythrocytes, the red blood cells, which are the actual substance carrying the oxygen, the chunky part of the soup.
Okay, so both the liquid and the cells are increasing.
They are, but at drastically different rates. The plasma volume increases much faster and in a much greater proportion than the red blood cell mass. The body can manufacture the fluid much quicker than it can synthesize new red blood cells.
So you end up with more blood overall, but it is fundamentally watered down. The concentration of red blood cells per deciliter of blood actually drops.
Exactly. This phenomenon is called the physiologic anemia of pregnancy. It is an entirely expected normal adaptation. When you look at the patient's lab work, their hematocrit, which is the percentage of the blood volume made up of red blood cells, drops simply because those cells are swimming in a much larger pool of plasma.
Okay, so as a nurse, if I see a slightly lowered hemoglobin and hematocrit in a pregnant patient, I shouldn't just immediately panic and assume they're bleeding out internally.
Right, it's expected.
But how do we distinguish between this normal watered-down state and true, dangerous iron deficiency anemia? Because instructors love to test the boundaries of normal versus abnormal.
They really do. And that is a major exam trap. You must memorize the cutoffs. Physiologic anemia is expected, but if the maternal hemoglobin drops below 11 grams per deciliter in the first or third trimester...
Or below 10.5 in the second trimester, right?
Exactly. That crosses the line into true iron deficiency anemia. At that point, it requires intervention. You would anticipate an order for iron supplementation.
Oh, and remember your pharmacology tie-in here. You always teach the patient to take that iron supplement with a source of vitamin C.
Yes, like orange juice, to drastically increase its absorption.
And to avoid taking it with milk, because calcium blocks iron absorption.
That is a brilliant connection to make. Examiners love testing cross-concept knowledge like that.
Okay, so understanding the labs is part of the baseline. But before we even get to the labs, we have to know how to take a proper obstetric history. If you're a nursing student, you're going to see the GTPL system on virtually every single exam you ever take in OB.
It's the universal language of obstetrics. GTPL stands for gravidity, term births, preterm births, abortions, and living children.
It seems straightforward, but honestly, it is notoriously easy to miscalculate when you're reading a complex patient scenario under the stress of a ticking exam clock.
Let's break that down piece by piece, because I know the math here can get incredibly tricky, especially when multiple gestations, like twins, are introduced into the narrative.
Let's start with gravidity, the G.
This is simply the total number of times the person has been pregnant, regardless of the duration or the outcome. The absolute most important thing to remember here is that twins, triplets, or any multiple gestation count as exactly one pregnancy.
Wait, so a woman pregnant with twins is just gravida 1?
Yes, gravida 1. You are counting the event of pregnancy, not the number of fetuses in the uterus. Oh, and don't forget to count the current pregnancy if the patient is currently pregnant.
Right. If she's sitting in front of you pregnant, that's a point for gravidity. That's a trap students fall into constantly.
All the time. Okay, so T is for term births. These are pregnancies delivered at 38 weeks of gestation or beyond.
And again, if she delivered twins at 39 weeks, that still only counts as one term birth event in the GTPL system, right?
Exactly, one event. Then P for preterm. Preterm births are deliveries that occur between 20 weeks and 37 weeks and 6 days of gestation.
Which is a critical window. It indicates the baby has reached the age of viability, meaning it actually has a chance of surviving outside the womb, but it hasn't reached full-term maturity.
Right. And what happens if the pregnancy ends before that 20-week mark?
That falls under A for abortion.
Yes. In obstetrics, the term abortion refers to any pregnancy loss prior to viability, which is generally accepted as prior to 20 weeks. This includes both spontaneous abortions, which the layperson calls miscarriages, and elective or therapeutic terminations.
And finally, the L living children.
Yes, the total number of currently living children. Now, here's where the twins finally get their due.
Oh, nice.
If that Gravida 1 patient delivered twins at term and both are alive, her L is 2, so her history would be G1, T1, P0, A, L2.
It's a puzzle, but once you understand the rules of the game, it becomes second nature. Gravidity is the event, term and preterm are the timing of the deliveries, abortions are the early losses, and living is the current head count.
You got it.
Okay, so once we have the history, we have to accurately date the current pregnancy. And that brings us to Naegele's rule.
Yes, the classic formula for calculating the estimated date of delivery, or the EDD. You take the first day of the last menstrual period, the LMP. You subtract 3 months, add 7 days, and then add 1 year.
Let's walk through a concrete example so the listener can really visualize this. Because I'll be honest, the moment a test question crosses a calendar year or deals with varying days in a month, my brain just freezes up.
Totally normal. Okay, let's say the patient reports the first day of her last menstrual period was October 14th, 2023. First step, subtract 3 months from October. That takes you back to July 14th.
Okay, tracking.
Second step, add 7 days to the 14th. That gets you to July 21st. Final step, add 1 year. The estimated date of delivery is July 21st, 2024.
See, it is relatively simple math, but highly testable. And I imagine the key phrase to watch out for in a clinical scenario is the first day of the last menstrual period, not the day it ended.
Precisely. The biological clock of the ovarian cycle begins on day 1 of menses. Now, of course, in modern practice, early ultrasound is the gold standard for dating a pregnancy, especially because many women have irregular cycles or just don't track their LMP accurately.
But for exam purposes and for initial clinical triage, Naegele's rule is a required competency.
Absolutely.
So we have the history, we have the dates, now we have to actually confirm the pregnancy. And this is where the terminology gets very, very specific. We have presumptive signs, probable signs, and positive signs of pregnancy.
The categorization here is crucial because it speaks directly to diagnostic certainty. Let's start with presumptive signs. The key to understanding presumptive signs is that they are entirely subjective. They are the changes experienced and reported by the patient.
Things like amenorrhea missing a period, nausea and vomiting, the classic morning sickness, extreme fatigue, or quickening.
Yes, quickening is a great example. Quickening is that initial, subtle, fluttering movement of the fetus felt by the pregnant person, usually occurring somewhere between 16 to 20 weeks of gestation. But think about why these are only presumptive.
Because none of them exclusively mean there is a baby growing in the uterus.
Exactly. You could miss a period because of extreme stress, intense athletic training, or a thyroid disorder. Nausea could be food poisoning or a GI bug. Fatigue could just be anemia or lack of sleep.
Even quickening could easily be mistaken for, like, excessive intestinal gas or peristalsis.
Yes. These signs presume a pregnancy, but they offer zero clinical proof, which moves us up the ladder of certainty to probable signs.
Okay, so probable signs are objective findings. They are usually assessed and documented by an examiner, like a nurse midwife or an obstetrician. These include observable physiological changes to the reproductive anatomy.
Like Hegar sign and Chadwick sign. Let's explain what those actually are, rather than just throwing out the eponyms.
Yeah, please. Hegar sign is a softening and compressibility of the lower uterine segment, right, which an examiner can feel during a bimanual pelvic exam.
Exactly right. And Chadwick sign is a deepened bluish-purple discoloration of the cervix and vaginal mucosa. This happens because of the massive increase in vascularity and blood flow to the pelvic region.
And here's the one that completely blows students' minds. The outline heavily emphasizes this. A positive urine or serum pregnancy test is categorized as a probable sign.
I know.
When I first learned that, it felt completely counterintuitive. You pee on a stick, it says pregnant. How is that not a positive sign?
It is one of the most common misconceptions, and examiners will mercilessly exploit it. You have to understand what a pregnancy test is actually doing. It is not detecting a baby. It is detecting a specific hormone.
Oh.
Human chorionic gonadotropin, or HCG.
And while HCG is primarily produced by the developing placenta of a normal pregnancy,
it can also be produced by other highly abnormal things. The most common example is a molar pregnancy, which is a benign proliferative growth of the placental trophoblast. There is no viable fetus, just a mass of tissue. But the HCG levels will be astronomically high, turning that pregnancy test instantly positive.
wow.
Furthermore, certain rare ovarian tumors secrete HCG. So a positive test makes it highly, highly probable that you are pregnant, but because of those pathological exceptions, it cannot be considered undeniable proof.
That makes perfect logical sense when you break down the mechanism. The test detects the chemical smoke, but it doesn't prove there is a fire. Which brings us to the highest level of certainty, positive signs.
Positive signs provide undeniable absolute proof of a developing fetus. There are no alternative medical explanations. There are only 3 positive signs you need to commit to memory.
Okay, grab your highlighters, folks.
First, directly hearing fetal heart sounds with a Doppler or fetoscope.
Yeah.
Second, directly visualizing the fetus via ultrasound imaging. Or third, the trained examiner actually palpating fetal movement through the abdomen.
So, hearing, seeing, or feeling the actual baby, period.
Correct. The fetus itself must be directly observed. Positive proves the baby is your memory anchor here.
Positive proves the baby. I love that. So let's zoom out for a second and talk about why we obsess over this baseline normal. Why does an L&D nurse need to know that cardiac output increases 30 to 50%?
Because if you don't intimately know the baseline of an altered physiological state, you are dangerous as a triage nurse. You cannot safely assess a pregnant patient if you don't know whether their vital signs are a beautiful normal adaptation or a glaring red flag of impending cardiovascular collapse.
Let's use heart rate as an example.
Perfect. During pregnancy, maternal heart rate normally increases by about 10 to 15 beats per minute, usually peaking around 32 weeks. The heart is working harder to pump that massively increased blood volume we talked about earlier.
Makes sense.
So if a patient at 34 weeks walks in with a resting heart rate of 95, that is largely expected. But if you didn't know the physiology, you might look at that 95 compared to a non-pregnant baseline of 70 and incorrectly assume she's in the early stages of hypovolemic shock or developing a systemic infection.
But conversely, if you assume every high heart rate is just pregnancy, you might miss the patient who actually is bleeding internally and compensating with tachycardia.
Exactly. It's a delicate balance. We have to clearly separate expected findings from concerning ones.
So what should a nurse reassure a patient about versus what should make them hit the panic button and call the provider immediately?
Well, we've already discussed physiologic anemia. Reassure them that it's normal. Another expected finding is dependent edema in the lower legs and ankles, especially at the end of the day.
Right, think about gravity in the anatomy. You have a heavy, fluid-filled uterus sitting right on top of the pelvic veins. It physically impedes the venous return from the legs, causing fluid to pool. That's totally expected.
Yep. Urinary frequency in the first and third trimesters is also expected first trimester because the changing hormones affect the bladder, and third trimester because the baby's head is literally using the bladder as a pillow.
Poor bladder. And Braxton Hicks contractions, the practice contractions.
Entirely expected. They're irregular, usually painless, and they don't cause the cervix to dilate. Reassure the patient, tell them to drink water and change positions, and they usually subside.
Okay, those are the reassuring elements. What about the danger signs? The findings that require immediate, urgent intervention?
These are the ones that threaten life. Let's look at edema again. Ankle swelling is normal, but sudden, rapid weight gain paired with generalized edema, especially swelling of the face, hands, and around the eyes, that is a massive red flag for preeclampsia.
It means fluid is shifting out of the vascular space in a pathological way.
Exactly. Any fluid gushing from the vagina is another one.
Because that indicates premature rupture of membranes. The sterile seal protecting the baby has broken, introducing an immediate risk of severe infection or umbilical cord prolapse.
Right. And any vaginal bleeding is an immediate priority. Severe, unrelenting headaches or epigastric pain are critical warning signs of worsening preeclampsia, which we will dive deeply into later.
And the one that always requires teaching, decreased fetal movement.
Yes, this is a vital nursing priority. You must teach the pregnant patient to count to 10. We ask them to take time each day to lie quietly and focus solely on the baby's movements. If they feel fewer than 10 distinct movements in a 2-hour period, they must report to the clinic or hospital immediately.
Why is that the threshold? Like, what does decreased movement actually tell us biologically?
It tells us about oxygenation. A fetus inside the womb operates very similarly to a person in a survival situation. If the placenta begins to fail and the oxygen supply to the fetus is reduced, the fetus will reflexively shunt its limited oxygen to the absolute vital organs, the brain and the heart.
Wow.
Right, to conserve energy and oxygen, it stops moving its limbs. Decreased fetal movement is often the very first clinical sign of fetal hypoxia.
I'm not getting enough air, so I'm going to stay perfectly still to survive. That is a terrifying but incredibly important mechanism to understand. It's not just the baby is sleeping. It could be the baby is suffocating.
Exactly. Another critical priority action regarding maternal positioning is teaching patients to avoid supine hypotensive syndrome.
The vena cava compression issue.
Yes. Anatomy is destiny here. The inferior vena cava is the massive blood vessel that runs right up the right side of the spine, carrying all the deoxygenated blood from the lower body back to the heart. In the later stages of pregnancy, if a patient lies completely flat on their back in the supine position, the sheer physical weight of the gravid uterus crushes that vena cava flat against the spine.
It's literally like stepping on a garden hose.
Exactly like that. Venous return to the heart is abruptly cut off. If the heart doesn't receive blood, it can't pump blood out. Cardiac output drops precipitously, maternal blood pressure plummets, and the patient will suddenly feel intensely dizzy, lightheaded, nauseated, and clammy.
And more importantly, perfusion to the placenta stops, meaning the baby loses oxygen. Right.
So what is the immediate life-saving nursing action if a pregnant patient passes out while lying on their back?
You don't run for medications, you don't call a code immediately, you simply turn them on their side. Specifically, the left-lateral position is optimal. Rolling them onto their left side physically displaces the heavy uterus off the vena cava, restoring blood flow instantly.
The memory anchor here is simple. Supine equals spine. Lying on the spine crushes the line. Left side is the best side.
Love it.
Let's synthesize this baseline section. If our listener is staring down a 100-question exam tomorrow, what are the 5 absolute must-know takeaways from maternal adaptation?
Okay, number 1. Master the GTPLL system. Remember that gravidity is the number of pregnancies and multiples count as 1. Number 2. No Naegele's rule cold. Last menstrual period minus 3 months plus 7 days plus 1 year.
Number 3. Distinguish your signs of pregnancy. Presumptive is subjective, probable is objective, including tests, but positive requires seeing, hearing, or feeling the actual fetus. Number 4. Supine hypotension is a mechanical obstruction fixed immediately by turning the patient to the left lateral position. Number 5. Decreased fetal movement is always an urgent priority to report because it indicates fetal hypoxia and energy conservation.
Perfect. We have established the murky, shifting baseline of a healthy pregnancy. But as nurses, our true test comes when that baseline is shattered by trauma or pathology. We've talked about the expected fluid changes, but what happens when the fluid leaking is blood? Let's transition into high-stakes bleeding emergencies.
This is where clinical judgment must be razor-sharp. Hemorrhage remains a leading cause of maternal and fetal morbidity and mortality worldwide. When a pregnant patient presents with bleeding, it raises an immediate critical question. What is the etiology?
Because not all bleeding is the same.
Right. To save both lives, we must rapidly categorize the bleeding by the trimester it occurs in, and crucially, by the presence or absence of pain.
Let's start early. First trimester bleeding. I know spontaneous abortion, miscarriage is the most common, but I want to talk about ectopic pregnancy, because the pathophysiology here is wildly interesting.
Oh, it really is.
I've read that a patient with a ruptured ectopic pregnancy might come into the ER complaining of intense shoulder pain. To a student, that feels geographically completely unrelated. Why does a reproductive crisis in the pelvis make your shoulder hurt?
It sounds like a trick question, but it's a classic manifestation of something called referred pain. In a normal pregnancy, the fertilized ovum travels down the fallopian tube and implants safely in the nutrient-rich lining of the uterus.
But in an ectopic pregnancy, that ovum gets stuck and implants outside the uterus, most commonly in the narrow, rigid fallopian tube.
Right, and the fallopian tube is not designed to stretch like the uterus.
At all.
So as the embryo grows, the tube stretches to its absolute breaking point until it violently ruptures. When that happens, you have a torn artery in the pelvis, leading to massive internal hemorrhage. That blood pools in the peritoneal cavity.
And blood is highly irritating to tissues, right?
Yes. Because blood is highly irritating, as it pools and travels upward in the abdomen, it eventually reaches the diaphragm and heavily irritates the phrenic nerve.
And the phrenic nerve innervates the diaphragm, but also shares pathways that connect to the shoulder area.
Exactly. The brain gets confused by the incoming nerve signals. It misinterprets that diaphragmatic irritation deep in the abdomen as sharp, stabbing pain localized in the shoulder.
Wow.
So if a female of childbearing age presents with unilateral lower quadrant stabbing pain, a missed period, and sudden shoulder pain, your alarm bells should be ringing for a ruptured ectopic pregnancy and hypovolemic shock.
That is incredible pattern recognition. And if we catch an ectopic pregnancy before it ruptures, what is the pharmacological intervention?
If it is unruptured and caught early via ultrasound, we can administer a medication called methotrexate. Methotrexate is technically a chemotherapy agent. It is a folic acid antagonist that stops rapidly dividing cells from multiplying.
It essentially dissolves the ectopic pregnancy, saving the fallopian tube.
Right. But if it is already ruptured, pharmacology is useless. The patient requires immediate surgical intervention, a salpingostomy or salpinectomy, to stop the bleeding and remove the damaged tube.
Okay, moving into the second trimester, we encounter a pathology that honestly sounds like science fiction. Gestational trophoblastic disease, commonly known as a molar pregnancy. This is the one that looks like a cluster of grapes on the ultrasound, right?
That is the classic description. A molar pregnancy is a genetic anomaly where the fertilization process goes entirely wrong. Instead of developing into a viable fetus and a healthy placenta, the trophoblastic villi, the cells that should form the placenta, proliferate wildly. They swell and become cystic fluid-filled vesicles that look exactly like a cluster of white grapes.
So there is no baby, just this rapidly expanding mass of tissue. What are the clinical hallmarks?
Because the trophoblastic tissue is what produces human chorionic gonadotropin, and you have massive overgrowth of this tissue, the maternal HCG levels skyrocket to absurdly high levels.
Which causes extreme intractable nausea and vomiting.
Yep. The uterus grows abnormally fast. A patient might measure at 20 weeks of size when they're only 10 weeks along. And critically, you will see a very specific type of vaginal bleeding. It is often described as dark brown, resembling prune juice.
Prune juice bleeding and a uterus growing too fast, that's a classic exam presentation. But the real danger of a molar pregnancy doesn't end when the mass is surgically evacuated, does it? Instructors always hammer home the long-term follow-up.
And for very good reason. This is a massive exam trap. After a molar pregnancy is evacuated through a D&C procedure, the patient must be instructed to strictly avoid getting pregnant for up to 1 full year.
A full year? That seems devastating to a patient who really wants a baby. Why is the restriction so severe?
Because up to 20% of complete molar pregnancies progress into choriocarcinoma, which is an incredibly aggressive, rapidly spreading reproductive cancer. The tumor marker we use to track this cancer is HCG.
Ah, I see where this is going.
So for a year, the patient must come in for continuous blood draws to ensure their HCG levels drop to 0 and stay at 0, proving no cancer cells remain.
And if they get pregnant during that monitoring year...
If they conceive, their HCG levels will naturally rise from the new healthy pregnancy, and we will have absolutely no way of knowing if that rising number is a new baby growing or a deadly silent cancer aggressively returning until it is too late. The diagnostic tool is blinded.
That is why highly reliable contraception for a year is a non-negotiable priority action. That physiology is just unforgiving. Let's move to the third trimester. This is where we see the two heavyweights that examiners absolutely live to test: placenta previa and abruptio placenta. Let's pit them against each other because distinguishing them is arguably the most critical differential diagnosis a nursing student needs to master.
They are the classic look-alike conditions with completely different mechanisms and presentations. Let's start with placenta previa. In a normal pregnancy, the placenta implants high up in the fundus of the uterus, well out of the way. In placenta previa, the placenta abnormally implants down in the lower uterine segment, either partially or completely covering the internal cervical and the doorway out.
So the baby's life support system is blocking the exit.
Precisely. And in the late third trimester, the cervix naturally begins to soften, efface, and slightly dilate in preparation for labor. As that lower uterine tissue shifts and pulls, it physically tears the placental vessels that are implanted right over it.
If that causes the bleeding, what are the hallmark findings we expect to see?
The defining characteristic of placenta previa is painless, bright red vaginal bleeding. Because the bleeding is just coming from the exposed surface vessels near the cervix, blood flows freely out of the vagina. There's no blood trapped inside to cause pressure or irritation.
Consequently, if you palpate the abdomen, the uterus remains soft, relaxed, and completely non-tender with normal resting tone.
Exactly.
Painless, bright red, soft uterus. Got it. Now, compare that to abruptio placentae.
Abruptio placentae is violent. It is the premature separation of a normally implanted placenta from the uterine wall. It literally rips away before the baby is born. This can be caused by maternal hypertension, cocaine use, or direct abdominal trauma like a car accident.
And because it's ripping away deep inside the uterus, the presentation is drastically different.
The hallmark of an abruption is the sudden onset of intense, localized, agonizing uterine pain. The bleeding is typically dark red, but here is the key difference. Often, the edges of the placenta remain attached, so the massive hemorrhage is trapped behind the placenta. It's concealed.
So you might not even see a lot of blood coming out of the vagina, but they are bleeding to death internally.
Exactly. And because that blood is trapped, pooling, and clotting within the muscle fibers of the uterus reacts by seizing up. If you palpate the abdomen of a patient with an abruption, the uterus feels board-like. It is rigid, hypertonic, and exquisitely tender to the touch. Furthermore, because the placenta is peeling off the wall, the baby's oxygen supply is abruptly cut off. You will almost certainly see severe fetal distress on the monitor, late decelerations, or profound bradycardia.
The imagery of a board-like uterus is terrifying, but so clinically helpful to remember. It's cramped up from all the internal bleeding. What are the priority nursing actions when a patient presents with either of these third trimester bleeding scenarios?
Any unexplained vaginal bleeding after 20 weeks is a priority to report immediately. But here is the critical, absolute, non-negotiable rule of OB nursing. If you remember nothing else, remember this. Never, ever perform a vaginal examination on a pregnant patient with unexplained vaginal bleeding.
Let's explain why. Because if a student is thinking, well, I need to check her cervix to see if she's in labor.
If the bleeding is caused by an undiagnosed placenta previa, the placenta is lying right over that cervix. If you blindly insert 2 fingers to check dilation, you can literally punch your fingers right through the highly vascular placental tissue.
Yeah.
You will cause a catastrophic exsanguinating hemorrhage. The patient and the fetus can bleed to death in minutes. Never do a digital exam. Instead, you advocate for a transvaginal ultrasound to visually locate the placenta.
And what if it is an abruption? What are our immediate life-saving steps?
With a severe abruption, you are managing rapid onset hypovolemic shock and fetal asphyxia. You must establish 2 large-bore IVs immediately to aggressively pump in isotonic fluids and cross-match blood products.
And administer high-flow oxygen at 8 to 10 liters per minute via a non-rebreather face mask to maximize whatever oxygen is still making it to the baby.
Exactly. And you prepare the operating room for an immediate emergent cesarean section.
This is incredibly intense. Let's bring it down to the memory anchor so students can lock this in.
The comparison is everything. Previa equals painless and bright red. Abruption equals agony, dark blood, and a board-like abdomen. And for our earlier topic, ectopic pregnancy. Unilateral stabbing pain plus referred shoulder pain.
If we synthesize this high-stakes bleeding section into the 5 ultimate takeaways.
Number 1, never perform a vaginal exam on a patient with unexplained bleeding. Number 2, placenta previa presents as painless bleeding with a soft, non-tender uterus. Number 3, abruptio placentae presents as severe abdominal pain with a rigid, board-like uterus and fetal distress.
Number 4, a ruptured ectopic pregnancy can present deceptively as sharp shoulder pain due to phrenic nerve irritation from internal hemorrhage. Number 5, molar pregnancies require strict long-term tracking of HCG levels with no pregnancy for a year to monitor for deadly choriocarcinoma.
Spot on.
Brilliant. We've covered structural visceral trauma, the ruptured tubes, the ripping placentas, its loud, obvious bleeding. But let's shift our focus to something far more insidious. Let's talk about the systemic killers, the vascular and metabolic changes that quietly threaten the pregnancy from the inside out. We are moving into hypertension and diabetes.
These are the medical heavyweights. They don't always present with the dramatic visual of a hemorrhage, but their capacity for devastation is just as high. And the pharmacology involved here is some of the most misunderstood in all of nursing education.
I want to start exactly there with the pharmacology because it's a perfect example of how clinical logic can trip you up. If a pregnant patient comes in with dangerously high blood pressure preeclampsia, the classic gold standard medication we hang on the IV pole is magnesium sulfate.
Right.
But magnesium sulfate is not actually a blood pressure medication, is it?
It is absolutely not, and that is one of the biggest misconceptions students carry into the clinical setting. It is an exam tract of the highest order. But to understand why we give it, we have to look at the continuum of hypertensive disorders in pregnancy. It is not just one disease. It's an escalating spectrum.
Let's map that spectrum out. Where does it start?
It begins with gestational hypertension. This is defined as elevated blood pressure greater than 140/90 that develops for the first time after 20 weeks of pregnancy. But crucially, in gestational hypertension, there is no proteinuria. The kidneys are still functioning relatively normally.
But if it escalates, we cross the line into preeclampsia.
Yes. Preeclampsia is the hallmark disease of obstetrics. It is hypertension after 20 weeks, accompanied by proteinuria, protein spilling into the urine. Or, if there isn't protein yet, it's accompanied by severe systemic features, indicating that the major organs are beginning to fail.
What is actually happening in the body to cause this? Like, why does pregnancy suddenly make the organs fail?
The core pathophysiology of preeclampsia is intense, widespread vasospasm and endothelial cell damage. The inner lining of the blood vessels becomes damaged, and the vessels clamp down incredibly tight.
Think about what happens when you constrict all the pipes in a plumbing system. The pressure skyrockets, but the actual flow of water to the endpoints is drastically reduced.
Exactly. In the body, this means severe ischemia, lack of blood flow, and oxygen to every major organ system, including the placenta.
So let's connect that mechanism to the severe features instructors always ask about. If the blood vessels are clamped down everywhere, what are the symptoms the patient reports?
If the vessels in the brain spasm and leak fluid, creating cerebral edema, the patient will report severe, unrelenting, continuous headaches. They will experience visual disturbances like blurred vision, seeing spots, or flashes of light.
And if you tap their knees with a reflex hammer, you will see hyperreflexia clonus because the central nervous system is incredibly irritable and swollen.
Yes.
And what about the classic right upper quadrant abdominal pain? I remember learning that is a terrifying sign.
It is a late and highly ominous sign. When those blood vessels constrict in the liver tissue becomes ischemic and begins to swell. But the liver is encapsulated in a tight fibrous sac called Glissen's capsule.
Ah, so it has nowhere to go.
Exactly. As the liver swells against that unyielding capsule, it stretches it, causing intense, severe pain in the right upper quadrant or the epigastric area. If you see a preeclamptic patient clutching their upper right abdomen, you are looking at a liver that is at high risk of literally rupturing.
That is horrifying. And if this cascade goes untreated, what is the ultimate endpoint?
It escalates from preeclampsia to eclampsia. The defining hallmark difference between the two is the onset of a generalized tonic-clonic seizure. The brain becomes so swollen and irritated that it seizes. This can cause maternal stroke, coma, and fetal death.
And alongside this continuum, you have a variant called HELLP syndrome, which stands for hemolysis, the breaking down of red blood cells as they force through clamped vessels, elevated liver enzymes from the liver damage, and low platelets because the body consumes them trying to patch the damaged vessel linings.
Exactly.
Okay, so bringing it back to our earlier question. We have a patient with severe preeclampsia. Their brain is irritable, their vessels are tight. Why do we hang a magnesium sulfate drip if it doesn't fix the blood pressure?
We administer magnesium sulfate because it's a potent central nervous system depressant. It is an anticonvulsant. It crosses the blood-brain barrier and acts as a neuromuscular blockade, competing with calcium to stop the irritable neurons from firing.
So we give it specifically and explicitly to prevent the patient from seizing.
Right. It might cause a slight transient drop in blood pressure because it relaxes smooth muscle, but that is a side effect. Its therapeutic goal is solely to protect the brain from eclampsia.
This requires intense nursing surveillance because you are deliberately depressing the nervous system of a pregnant woman. We have to separate the expected side effects from dangerous toxicity. What does a patient look and feel like when they first get magnesium?
Magnesium makes the patient feel absolutely terrible. That is expected. As the smooth muscles relax and the CNS slows down, they will experience intense feelings of flushing, heat, and diaphoresis.
They'll feel lethargic, sedated, and weak, almost like they have a severe case of the flu.
Yeah, you must reassure them that this is the expected mechanism of the drug.
But the line between therapeutic sedation and lethal toxicity is razor thin. What are the concerning signs that the nervous system has been depressed too far?
This is where you earn your license as an OB nurse. You must monitor for mag toxicity relentlessly. Think about the mechanism. If it depresses the nervous system, toxicity means everything slows down until it stops entirely.
So what's the classic triad of toxicity we need to memorize?
First, the absence of patellar deep tendon reflexes. They go from hyperreflexic to zero reflexes.
Right.
Second, respiratory depression. If their breathing rate drops below 12 breaths per minute, the diaphragm is failing. Third, severe oliguria urine output dropping below 30 milliliters per hour.
Why does the urine output matter so much with magnesium?
Because magnesium is entirely excreted by the kidneys. If the damaged preeclamptic kidneys stop making urine, the magnesium builds up exponentially in the blood, driving them into toxicity and cardiac arrest.
So what is the priority immediate action if I assess a patient on MAG and find 0 reflexes and a respiratory rate of 9?
You do not leave the room. You do not wait to call the provider. Your immediate first action is to reach up and stop the infusion pump. Stop the drug.
Then you administer the specific chemical antidote to reverse the neuromuscular blockade, calcium gluconate. You must always have calcium gluconate readily available in the room when hanging magnesium.
Calcium cures the MAG. That's a great way to remember it.
Now, let's pivot to the other metabolic heavyweight, gestational diabetes mellitus, or GDM. This is impaired glucose tolerance first recognized during pregnancy. The pathophysiology here is so elegant in a destructive way. I want to talk about the baby. Instructors love to ask about the neonatal complications of GDM.
You do, because it requires you to understand the placenta as a semi-permeable filter. In a mother with uncontrolled GDM, her blood sugar is chronically high. Here is the critical mechanism. Maternal glucose easily crosses the placenta to the baby, but maternal insulin does not cross the placenta at all.
So the fetus is sitting in a continuous bath of high-sugar syrup, but it has no help from mom to process it.
Exactly. So the fetal pancreas has to kick into a massive overdrive. The tiny fetus produces astronomical amounts of its own insulin to process all that incoming sugar. And in a developing fetus, insulin doesn't just manage sugar, it acts as a very potent primary growth hormone.
Which leads to macrosomia, a very, very large baby.
Yes. A baby that grows too large, leading to difficult vaginal deliveries, shoulder dystocia, and birth trauma. But the most testable consequence happens exactly at the moment of birth.
When the umbilical cord is cut.
Think about the physics of that moment. The cord is clamped and cut. Instantly, the massive continuous supply of maternal glucose is completely shut off. But the baby's hyperactive pancreas doesn't know that yet.
Right. It is still pumping out massive amounts of insulin.
Exactly. That huge surge of insulin quickly metabolizes whatever tiny bit of glucose the newborn has left in its bloodstream. The result:
Severe, rapid onset neonatal hypoglycemia. The baby's blood sugar crashes.
Precisely. It is highly counterintuitive for students. They think the mom had high sugar, so the baby will have high sugar. No. The baby of a diabetic mother is at extreme risk for profound hypoglycemia within the first hours of life. You must aggressively monitor the newborn's blood glucose and initiate early, frequent feedings.
What a brilliant breakdown of the why behind the disease. Let's package this heavyweight section into our 5 critical takeaways.
Okay, number 1. Preeclampsia officially escalates to eclampsia the exact moment a seizure occurs. Number 2. Severe preeclampsia involves multi-organ ischemia, presenting as severe headache, visual changes, and highly dangerous right upper quadrant liver pain. Number 3. Magnesium sulfate is given strictly as an anticonvulsant to protect the brain, not to lower blood pressure.
Number 4. Magnesium toxicity manifests as a loss of deep tendon reflexes, respiratory depression, and low urine output. Stop the pump immediately. Number 5. The antidote to MAG toxicity is calcium gluconate.
Spot on.
We have managed the blood pressure, we have managed the sugars, we have stabilized the bleeding. But what happens when the mother's body simply decides that it is time to evict the pregnancy weeks or even months too early? Let's transition into early onset labor and premature rupture of membranes. Because if we zoom out and look at the bigger picture of prematurity, there is one organ system that is the absolute ultimate limiting factor for a baby's survival outside the womb.
And that organ system is the fetal lungs. A fetus can be perfectly formed, its heart beating beautifully, but if those tiny alveoli in the lungs are stuck together because they lack surfactant, the baby will suffocate the moment it tries to take a breath of air.
Preterm birth is the leading cause of neonatal morbidity and mortality globally. Our entire clinical goal in this phase is either to stop the labor entirely, or, if we can't stop it, to buy enough time to artificially mature those fragile lungs.
Let's define the parameters. Preterm labor is diagnosed when a patient experiences regular uterine contractions accompanied by documented cervical changes, effacement, and dilation occurring between 20 weeks and 36 weeks and 6 days of gestation.
But clinically, how do we distinguish between a patient who is just having uncomfortable Braxton Hicks practice contractions and a patient who is actively, dangerously going into preterm labor?
It can be very difficult to tell just by feeling the abdomen. That is why we rely on a highly specific diagnostic biochemical marker, the fetal fibronectin test, or FFN swab.
I remember learning about this, and it was described as a kind of biological glue. How does that testing mechanism actually work?
Fetal fibronectin is a glycoprotein. You can think of it precisely as biological adhesive that binds the fetal amniotic sac to the maternal lining of the uterus. Normally, you expect to find this glue in the vaginal secretions at the very beginning of pregnancy as things are attaching, and again at the very, very end of pregnancy when the body is breaking down that glue to prepare for labor.
But in the middle of the pregnancy, it shouldn't be there.
Exactly. Between 24 and 34 weeks of gestation, that glue should be solidly intact up in the uterus. If we swab the vaginal secretions during that window and the test comes back positive for fetal fibronectin, it means the glue is breaking down prematurely, usually due to inflammation or infection. It indicates a very high risk that the patient will go into preterm labor within the next 7 to 14 days.
It's a warning flare. The structure is degrading. Now, I want to talk about what triggers these early contractions because there is an incredible physiological feedback loop here involving hydration. I asked a professor once, if being dehydrated can trigger preterm labor, are contractions just the uterus's way of complaining that it's thirsty?
In a beautifully simplified way, yes. Let's look at the endocrinology of why that happens. When a pregnant patient becomes dehydrated, maybe it's summer or they have a stomach bug, their overall blood volume drops and the concentration of their blood increases.
And the brain senses this hyperosmolarity.
Specifically, the posterior pituitary gland in the brain detects the lack of water. In response, it secretes antidiuretic hormone, or ADH, which travels to the kidneys and tells them to hold on to water to save the body.
Makes perfect sense, save the water, but where do the contractions come from?
Here is the anatomical catch. The posterior pituitary only secretes two hormones, ADH and oxytocin, and they are synthesized and stored right next to each other. Oxytocin is the primary hormone responsible for stimulating violent uterine contractions.
Oh, wow.
When the brain frantically triggers a massive release of ADH to fight dehydration, it often spills over and co-releases a surge of oxytocin along with it.
That is fascinating. So the body accidentally sparks labor while just trying to fix dehydration, which is why one of the very first nursing interventions for a patient reporting early contractions is aggressive IV fluid hydration. Shut off the ADH and you shut off the oxytocin.
Exactly. Fluid hydration and modified bed rest in the left lateral position are your first-line defenses. But if that doesn't work and the cervix is changing, we have to pull out the heavy pharmacological artillery to stop the uterus. These medications are called tocolytics. Toco, meaning labor, tocolytic, meaning to stop or break.
What are the high-yield tocolytics we need to know?
The first is nifedipine. You likely know nifedipine from MedSurg as a calcium channel blocker used for hypertension. But here we use it to block calcium from entering the smooth muscle cells of the uterus. Without calcium, muscle fibers physically cannot contract. The uterus relaxes.
And the second one is terbutaline.
Terbutaline is a beta-adrenergic agonist. It stimulates the sympathetic nervous system, the fight-or-flight response, which has the effect of relaxing uterine smooth muscle. But because it triggers the sympathetic system, you have to expect massive collateral side effects.
Think of an adrenaline rush. What does the patient experience?
The patient will feel terrible. They will experience profound tachycardia, severe tremors, palpitations, and nervousness. That is an expected response. However, you as the nurse must hold the medication and report immediately if the maternal heart rate exceeds 130 beats per minute or if she complains of chest pain, as that indicates dangerous cardiac toxicity.
And what about magnesium sulfate? Does it make an appearance here?
It does. While it can act as a smooth muscle relaxant in the context of extreme preterm labor, say, delivering at 28 weeks, we administer magnesium primarily for fetal neuroprotection. It stabilizes the tiny fetal blood vessels in the brain, drastically reducing the risk of severe cerebral palsy in premature infants.
But there's a massive exam trap involving magnesium and nifedipine.
The deadliest trap. You must never administer nifedipine and magnesium sulfate to a patient at the same time. Both of these drugs powerfully block calcium at the muscular level. If you give them concurrently, you will cause profound complete skeletal muscle blockade. The patient's diaphragm will be paralyzed, and they will literally stop breathing.
Okay, so we are throwing all these tocolytics at the uterus to buy time. What are we buying time for?
We are buying time for betamethasone. Betamethasone is a potent corticosteroid. We administer it intramuscularly to the mother. It crosses the placenta and aggressively forces the immature fetal lungs to accelerate their development and start producing surfactant.
Surfactant is the soaky substance that coats the inside of the alveoli, preventing them from collapsing and sticking together when the baby exhales.
Right. The dosage timing here is highly testable. It is given as 2 12-milligram injections spaced exactly 24 hours apart, and it requires a full 24 hours after the second dose to achieve maximum efficacy. That is why the tocolytics are so important. We just need to keep the baby inside for 48 hours so the steroid can build those lungs.
the memory anchor. Betamethasone builds baby's breathing.
Exactly.
Now, what happens if the situation accelerates and the water breaks early? Premature rupture of membranes, or PROM. What is the immediate crisis we are worried about?
If the membranes rupture before labor, the sterile seal is gone, risking infection. But the acute, immediate catastrophic emergency is a prolapsed umbilical cord.
How does that happen?
Imagine the uterus is a balloon full of water with a baby floating inside. If the baby's heavy head is not firmly engaged and wedged deep into the maternal pelvis, there is space below it. When the water breaks, the fluid violently rushes out through the cervix. That rushing fluid can sweep the flexible umbilical cord right past the baby and down into the birth canal.
And then the baby's head drops down right behind it.
And crushes the cord against the hard bones of the maternal pelvis. The lifeline is entirely pinched off. The baby loses all oxygen instantly.
So what is the absolute priority nursing action the second a patient reports, "I think my water just broke"?
You do not leave to get a towel. You do not check their blood pressure. Your immediate first priority action is to assess the fetal heart rate monitor. You must rule out a prolapsed cord. If the cord is compressed, you will instantly see abrupt, severe, variable decelerations or profound, sustained bradycardia.
And how do we confirm that the fluid leaking is actually amniotic fluid and not just urine from a compressed bladder?
We use a simple diagnostic tool called nitrazine paper. Normal vaginal secretions in urine are slightly acidic. Amniotic fluid is highly alkaline. If you touch nitrazine paper to the fluid and it turns a stark dark blue, that is a positive confirmation of ruptured membranes.
Okay, let's condense this highly complex segment into the 5 high-yield takeaways.
Number 1, 5-day hydration helps prevent preterm labor by shutting down the ADH and oxytocin cascade. Number 2, a positive fetal fibronectin swab strongly predicts an impending preterm delivery. Number 3, terbutaline relaxes the uterus but causes expected intense maternal tachycardia. Hold if HR is over 130.
Number 4, betamethasone is given IM to the mother to rapidly mature fetal lungs, and it needs time to work. Number 5, always, always, always check the fetal heart rate immediately after membranes rupture to rule out a deadly prolapsed cord.
Spot on.
Excellent. We are in the home stretch. We have battled the massive hemorrhages, the hypertensive crisis, and the premature contractions. Let's finish with a segment that requires a completely different type of vigilance. Segment 5, the sneaky threats. Maternal infections. Because these complications might be completely asymptomatic for the mother. She might feel perfectly fine, but they can be absolutely devastating, even fatal for the neonate.
And that reality is the entire driving force behind our rigorous prenatal screening protocols. We test every single patient for these pathogens because the stakes for the newborn are simply too high, and the infections are often entirely silent.
Let's start with the one that gets talked about constantly in the 3rd trimester. Group B streptococcus, or GBS. What is it, and why are we so afraid of it?
Group B strep is a relatively common bacterial infection. For about 25% of healthy, non-pregnant individuals, GBS naturally colonizes the gastrointestinal tract and the vaginal flora. It doesn't cause them any harm, no symptoms, no disease. The mother is perfectly fine.
But the baby is not.
Exactly.
No.
The fetal immune system is completely naive. If a GBS-positive mother goes into labor, her water breaks, and the baby descends through that colonized birth canal, the infant aspirates or ingests the bacteria. Within hours of birth, that bacteria can rapidly multiply and cause catastrophic early-onset neonatal sepsis, profound pneumonia, and meningitis.
So the goal is to prevent that transmission. How and when do we screen for it?
We perform a routine vaginal and rectal swab culture on every single pregnant patient universally between 36 and 37 weeks of gestation.
Okay, here's a question that always confuses students. If I swab a patient at 36 weeks and find out they have this dangerous bacteria, why don't I just give them a prescription for oral antibiotics right then and there to clear it up before they go into labor? Why do we wait?
That is a brilliant question and a very common exam trap. You have to think about the nature of normal flora. If you give the mother oral antibiotics at 36 weeks, you will successfully kill off the GBS. But because it is part of her natural gastrointestinal flora, the bacteria will simply repopulate and grow right back within a week or two. By the time she goes into labor at 40 weeks, she will be heavily colonized again, and the baby is at risk.
So treating early is useless. When do we intervene?
We only intervene when the baby is actively making its exit. If a patient is GBS positive, the priority nursing action is to administer intrapartum antibiotic prophylaxis. Typically, this is penicillin G or ampicillin given via IV piggyback every 4 hours during active labor. The goal is to saturate the maternal bloodstream and the amniotic fluid with antibiotics precisely at the moment the baby is passing through, acting as a chemical shield.
And what if a patient arrives in precipitous labor or they had no prenatal care and we have absolutely no idea what their GBS status is?
In the case of an unknown GBS status, we treat them prophylactically with IV antibiotics if they present with significant risk factors for infection. The major risk factors are a maternal fever during labor, or if they have experienced prolonged rupture of membranes, meaning their water has been broken for 18 hours or longer, giving bacteria ample time to migrate up into the uterus.
GBS gives baby sepsis. Treat during labor. That is a perfect memory anchor. Let's shift to a viral threat. HIV. The protocols surrounding an HIV-positive pregnancy are incredibly strict, and instructors love testing the nuances of perinatal transmission.
The entire goal with HIV is to prevent vertical transmission passing the virus from the mother to the baby. Without intervention, the transmission rate is devastatingly high. But with modern antiretroviral protocols, we can drop that transmission rate to less than 1%.
What does that protocol look like practically for the nurse?
The cornerstone of the treatment is an antiretroviral medication called zidovudine, also known as Retrovir. The mother must remain on her oral antiretroviral therapy throughout the entire pregnancy. Then, during delivery, the nursing priority is to administer zidovudine intravenously, starting at least 3 hours prior to a scheduled C-section and continuing until the umbilical cord is clamped.
And the baby gets treated as well.
Yes, the infant receives oral zidovudine syrup immediately at delivery and must continue taking it for 4 to 6 weeks postpartum to eradicate any viral particles that might have slipped through.
Let's talk about the mode of delivery because there is a very specific nuance here. I was always taught that an HIV-positive mother must have a cesarean section, but is that an absolute rule?
It is not an absolute rule, and that is exactly the trap examiners use. An HIV-positive mother can safely have a vaginal delivery, but only if her viral load is exceptionally low, specifically documented at less than 1,000 copies per milliliter of blood near the time of delivery. If the viral load is greater than 1,000, or if it is unknown, a scheduled cesarean section at 38 weeks is strictly required before the water ever breaks.
Because once the water breaks, the blood and fluids mix. And speaking of mixing fluids, there are major nursing contraindications during the labor of an HIV-positive patient.
Absolutely. The nursing priority is to ruthlessly avoid any invasive procedure that could puncture the fetal skin or mix maternal and fetal blood. You must never place an internal fetal scalp electrode. You avoid vacuum extraction or the use of forceps during delivery. And the provider should aggressively avoid performing an episiotomy.
No poking, no pulling. And after birth, what about feeding? Breast is usually best, but not here.
Correct. In developed countries with access to safe formula, an HIV-positive mother must be explicitly instructed not to breastfeed. The HIV virus is actively transmitted through breast milk. Formula feeding is a strict requirement.
The final infections we need to touch on are the torch infections and STIs, specifically chlamydia and gonorrhea. These can cause severe congenital anomalies, but I want to focus on the immediate newborn intervention.
When a baby passes through a birth canal infected with untreated chlamydia or gonorrhea, the bacteria heavily colonizes the newborn's eyes. This leads to a severe purulent conjunctivitis called ophthalmia neonatorum, which can rapidly progress to permanent blindness.
So we treat the baby immediately.
Yes. The universal priority nursing action is to administer erythromycin ophthalmic ointment into the lower conjunctival sac of both eyes of every single newborn immediately following birth, usually within the first hour. It provides mandatory prophylaxis against this blinding infection.
Let's lock this final section in. What are the 5 non-negotiable takeaways for maternal infections?
Number 1, screen everyone for Group B strep with a swab at 36 to 37 weeks. Number 2, treat GBS with IV penicillin only during labor to provide an active shield, not weeks before. Number 3, HIV management requires continuous zidovudine during pregnancy, an IV drip during labor, and syrup for the newborn for 6 weeks.
Number 4, HIV-positive mothers must never breastfeed to prevent viral transmission. Number 5, erythromycin eye ointment is a mandatory intervention to protect every newborn's eyes from gonorrheal and chlamydial blindness.
That's exactly right.
Wow. Take a deep breath. We have covered a truly massive, formidable amount of ground today. For every nursing student listening, leaning into this material, you need to acknowledge the complexity of what you are mastering. You are no longer just memorizing isolated flashcards. You are now armed with high-yield, life-saving clinical judgment. You understand the shifting baseline of adaptation. You know the exact mathematical breakdown of GTPO. You know why you will never perform a vaginal exam on a bleeding third trimester patient.
You can see the pathophysiological cascade of preeclampsia and know exactly why magnesium sulfate is hanging on that IV pole and why you must stop it if the reflexes disappear.
You know how to protect tiny, fragile fetal lungs and how to shield a neonate from silent infections. You have the tools to keep two patients safe at once.
You do have the physical tools, and you understand the disease mechanics. But before we sign off, I want to leave you with one final provocative clinical judgment question to ponder as you return to your textbooks and your clinical rotations. Throughout this entire deep dive, we have focused intensely on the physical interventions. We talked about replacing massive hemorrhage, aggressively depressing the central nervous system to stop seizures, and strictly confining a mother to bed rest to stop premature contractions. But I want you to step back and think about the profound, often devastating psychological impact of all these life-saving interventions.
That is such an important pivot. We treat the disease, but the patient endures the treatment.
Exactly. Imagine you have a young patient who thought she was having a beautiful, normal, low-risk pregnancy. Suddenly, her blood pressure spikes. She is admitted to the antepartum unit and placed on strict, isolating bed rest. We hang a magnesium sulfate infusion that makes her feel hot, flushed, incredibly weak, and completely unable to think clearly. She is staring at the ceiling tiles for days on end, terrified that her baby is going to be born months too early, or that she might have a stroke. She can't hold her older children. She feels completely stripped of control. The diagnostic picture is murky, and she feels it. As a nurse, how does your care shift? How do you transition from just successfully saving her physical body and the fetus to actively, intentionally protecting her mind, her dignity, and her sense of autonomy in the midst of a terrifying medical crisis?
That right there, that is the very essence of elite holistic nursing. The pharmacology and the protocols might save the life, but it is the nurse who saves the human being. Keep questioning the material, keep connecting the underlying physiological dots, and go absolutely crush those exams. Remember, it is never about just memorizing. It is about recognizing the patterns that save lives. Until next time, keep diving deep.